glaucoma care. The stratification of diseases, the disease that I showed is not very linear kind of stratification, and everybody may not fit into one of the category. But this is, I thought that this is a more practical way of doing things. So what I have done is, if you see this, this is just says that post iridotomy occludable angle, but it may be a plato iris syndrome, or if a patient is monocular, or somebody has side effects of treatment, they are put into there so that when a faculty is visiting, those patients are pooled. So now we tag the patients into which of the category these are, and accordingly the receptionists are trained to give appointment with the faculty when they are coming, and that's how we are doing. Now I did some experiments regarding the diagnostic ability of screening tests, and as we were talking earlier, so I looked at these three common tests which we are looking for screening, and they show a good specificity, though the sensitivity is less. But the problem is that the prevalence of the disease is low in the community, and that's the whole big problem. So if you look at the positive predictive value, that's really low, even though the specificity is quite good. So then I did some simple experiments. One is that you just modify the cutoff of Van Herrick system. So if you want to rule in the disease, you made it more strict. Instead of cutoff of grade 2, we make it grade 1, and see the specificity has increased, PPV has increased. Similar, if you want to rule out, you make it more lenient cutoff, and your sensitivity and NPV has increased. The other strategy is to do a test combination strategy. So we did a combination of simple biometry and Van Herrick, and found that the predictive value is quite high and at least as good as all these sophisticated diagnostic techniques. So there are many challenges. There is no single reliable diagnostic test for glaucoma. If you screen patients, what do you do for the screen patients? There are several rural-urban differences, which Mona also said just now. But I think we can do this. There is possibility of adding a vertical program. Agreed, I could do this because of the existing horizontal network, which is a very big thing that LVP has done, otherwise it was not possible. But still we can think in this direction, because most of the decisions in glaucoma are clinical, and we rarely need these sophisticated instruments in each and every patient. It can be managed, so we say that it can be managed at a rural center by traveling, say, just 2 days in a month. You can make a large difference to the people. So these are the 5 things Madam had put when she put up these course together. And I think by this model we may be doing something good at these 3 levels, but still there is many things to be done. Now this awareness we are even doing in rural centers in World Glaucoma Week, but it's not sufficient, because I look at the prevalence, hospital prevalence of glaucoma at each of these centers, it is still 50% of what is supposed to be in the community. So that means we are still lacking there. And maybe we need to do a brainstorming, we decide, make more guidelines, decide further path, unite and make things more clear, and decide what exactly we are going to do, and that may make difference in future.
Thank you, Nikhil. Really is a beautiful model and truly workable model. Now I'll request Dr. Venkatesh to get into the innovations put together as to truly how can we reduce the training, how can we get the more sensitive and more specific things with, as Nikhil showed, not really in Humphrey, something cheaper and something like that, and better results.
No audio. Thank you, madam. I think it's a very important course. It's very rare to have a course like this in all India, but it's so important that we'll have to think how we can make the screening better, and there's no better way than doing a good opportunistic screening. Now, wherever we get an opportunity, we need to get and see how we can diagnose more glaucoma much earlier. Okay. So I'm going to share some of the innovations we have done in the recent past back at Pondicherry, where I practice glaucoma. Some of my colleagues, Dr. Pavan, Kavita, they have all been in the background. And we know this is a kind of problem we have, the distorted map of blindness. You would have seen several years back, so I just want to recollect. So this is how the practicing or the ophthalmologist who can take care. When you see that, the whole map shrinks in certain places, including India, Africa, the rest of developing world. So there's a lot of scarcity in human resources. So we need to kind of think about a better way in all these things. But the best at this point of time to really focus on the high-risk patients and also on doing a good opportunistic screening. So I'm going to share with you some of the things. So I'm just going to share with you this family, who came some time back. So this is a mother of our insurance expert. Her name is Devi. She's sitting right behind. And she brought her mother, and mother had a POAG, definitive POAG. And then we asked Devi, can we see all her siblings? And you see them all sitting there. So she said, today I have a housewarming ceremony, and they have all come from their native villages. We said, you get them all in the afternoon or around 4 o'clock. So they all are there. You can see all the 4 sisters. 3 had glaucoma, except 1. So out of the 4, 3 had glaucoma. And we had one more brother who was examined the next day because he had gone out to get some dinner or something, arrange something. So next day we saw him. Luckily, he also didn't have. So 3 out of 5 had glaucoma. So I'm sure in your practice you are seeing several families. But the point is, we kind of do an ad hoc screening. Whenever we tell it's possible, some people bring, some people don't tell their siblings. And interestingly, you'll see a lot of rivalry between siblings these days. They don't even tell their siblings, right? I ask them, can you tell your brother or sister? Sir, it's been a long time since I spoke to him. Why are you worried about him? You worry about me who is sitting in front of you. So these stories are really kind of little sad. So we thought we should do something better. And that's when we kind of started this family screening model. First, it was more like a paperwork like this. We have these case records where we enter all the information, and everything we entered into a software. Okay, like your brother, sister, how many, we take their contact numbers. So the counselor, we put an additional counselor to do this job, and everything was kind of here. And we used to give a sibling screening card to the proband. We write a sibling's name, and then we ask them to just pass this card to the sibling whenever they meet them or their children, and then we enter into the program and we start tracking them, reminding them. But even this wasn't very successful. So we had to think even out of the box. So when we had EMR, we had incorporated the same software into our electronic medical record. So automatically when you take history, it is all uploaded there, and the counselor has to take their contact numbers, and once their contact numbers are done, they get an automated SMS immediately and a voice message, because a lot of people don't even read messages these days, like they are into WhatsApp. So it's difficult to connect through WhatsApp. So they get a voice call, okay, that your sibling was screened. I mean, they have a doubtful glaucoma. It will be nice for you to get your eyes tested. And we kind of worked on this, and we know how the prevalent of angle closure in India and South India. So now we worked on something where everything is kind of automated. See, we didn't want this to happen ad hoc. It was not happening. So we wanted to make it like a system. So now this family screening has become a part of the system. So every day we screen close to 20 patients in Pondicherry alone who are family members. And through a project, we offer a free screening for them, the basic screening. Rest of the investigations are done at a later stage. But doing something like this, in your daily practice, you can start family people coming. Otherwise, it will be like World Glaucoma Month or week. When we do those family screening, it's not going to really help. We may reach maybe 10, 100 people. But if you want to reach thousands of family members, you may have to do something like this. If you are interested, we can definitely help you. So there is a process for it. So this is the message which goes to them. And then we track them, we give missed calls, and then this is like something like getting a consent for them to send messages about glaucoma, and then we get them for examination. And this has significantly increased the way at least we touch the family members. From here, I'll just quickly go to vision centers. No, you know the vision center model in LV Prasad. So we have network of 100 plus vision centers now. So this is how they function. No, they are in a semi-urban rural area. Two optometrists are the vision technicians who are well trained in the base hospital do this. So one is a person who registers and then takes care of the optical and medical shop. The other person does the comprehensive eye examination. So she is a trained optometrist. And these two people, they roughly see 25 to 30 patients daily in a vision center. And you can see they do comprehensive eye evaluation. So they have a applanation tonometer. They can visualize the fundus with 90D. And wherever they suspect posterior segment, any issues, then they image with a fundus on phone. This is a slightly older version, it's an older video. Now we have attached the fundus on phone right in the slit lamp. So you don't have to move every time. They just have to move the slit lamp or the fundus on phone. And it is also attached to the EMR. So they don't have to remove the cable and upload the images. The images are automatically transferred into the fundus photo area of the EMR now. And then they get a teleconsult with a resident, usually a senior resident, second or a third year resident. They are posted monthly for doing this teleconsult, and then they keep changing. So what usually happened is we get posterior segment diseases being referred, but many may be false positives also. No, there are a lot of suspects and patients who are coming, but still the true cases were being kind of found. So then we decided that we are still missing when they see the 90D and they are taking images wherever they suspect posterior segment disease. So we thought, can we image every patient who needs a fundus image? So anybody above the age of 35, 40, can we image and see? So we did a step wedge cluster randomization in 4 of the vision centers which you see. So 50% we did standard of care. Standard of care is whenever you need a fundus photo, they'll take. The other was routine photography. No, the other group, they did routine photography for the intervention group, and they all had a teleconsultation. So what we found was between the control and the intervention, there was a significant increase in the posterior segment diagnosis, especially in diabetic retinopathy, macular edema, glaucoma suspects. You can see 16 and 38. No? So there was a significant increase in some of the cases, and also we found that the significant increase was in the non-urgent referral, which is like a mild NPDR, moderate NPDR, early glaucoma changes. The urgent referral, already if they had a visual disability, it wasn't big difference. But the non-urgent, which are the earlier cases which we want to find and start creating awareness or start treating them, kind of significantly increased between these two groups. So we went on to publish this work some time back, and we said that it's good to fundus image, because technicians are good, but they can miss some of these conditions. So it's good to image, and these images will really help the teleconsultation part. Finally, I'll touch upon the outreach. I'm sure many of you do outreach. We have been doing outreach for several years, but it's been always bothering that you want to piggyback, but you're still not piggybacking. You're still focused on cataract. At the end of the day, you're bringing cataract in buses and then forgetting other conditions. So we thought we should go beyond. So at least now in Pondicherry, you can see camps happening in this way. We have electronic medical record in iCamp. We have low-cost technologies being used in iCamp. So you can see the laptop for all the entry. There's a handle slit lamp between the doctors to share, and the optometrists, they do refraction, and then they get a eye care tonometry. The pressure is, again, it's seamlessly connected to the EMR. It goes to the EMR, and then you can see we use the Bosch camera here because it's very easy to do in a campsite than on a fundus on phone, which is a little heavy to hold. And then the images are transferred again to the electronic medical record, so that you know how difficult it is to see a fundus in a campsite. The hygiene of the patient, the environmental conditions around you. So even if you give a direct ophthalmoscopy, indirect, it doesn't happen. At the end of the day, they say that we didn't see any diabetic retinopathy or glaucoma, which was bothering. So this model, again, we did a trial comparing the traditional eye cams in Aravind versus the novel method of using eye care and fundus photography, EMR, and we found again a significant increase in the diagnosis of posterior segment disease. So this is, again, we are trying to really piggyback on the cataract model so that now we get more referral of these conditions. And the point is not just referring, we need to even close the loop. Like Madam was mentioning, some of the advanced cases, even we tried to bring them with the cataract patients, do a combined surgery or a trabeculectomy, or maybe a laser for PDR, because now we have the Chief Minister Comprehensive Insurance Scheme, which is covering all this. So they allow us to bring the patients and do the treatment. So the only issue which we saw was the slight increase in time, which is well understandable. It takes 1.5 hours more than the traditional, where you're just putting torchlight or doing a shear stonometry is definitely different. But we understand that it may become cost effective. We are working on that study also to see whether it is cost effective. But once you start doing as a routine, I'm sure this time would also come down, because it's with practice we see people do brilliant fundus photography, and then the flow also becomes much smoother. So this, again, we took into a publication during the COVID time, where we did this trial before COVID, and we concluded by saying that use of digital fundus photography in a novel eye cam resulted in increased detection and referral of posterior segment disease. So with this, I'm just going to finally touch on the work which we are just doing. I got the results very hot out of the press from the team Remedio, which I'm working with, and we are working in 6 of our vision centers. Of the 15 vision centers we have in Pondicherry, I'm sure you know their offline AI for DR is working brilliantly, and now we are closely working with them in the glaucoma part, where you take an image, immediately the software would tell you whether it is a sufficient quality or insufficient. Insufficient, you have to repeat the image. If it is sufficient, then it crops the area of interest like this. And then there are 2 things which immediately happen. One is the segmentation, and the other is the classification. Segmentation, more, it looks at the disc margin, the cup margin, and the next level, it will also look beyond that. What is the recommendation for referral? It will look into the, and then it will give you a PDF printout like this, and say within the disc and beyond disc, what it looked for, even a subtle RNFL defect, peripapillary atrophy. So it is trained to look into all these things beyond the cup to disc ratio, and then like you see the subtle defect here, which the map picks up. And then it gives you a PDF record whether to refer or not. So what we did was, so we did this trial a few months back. We looked at 299 patients with the image-based diagnosis of glaucoma for referral warranted glaucoma. When it referral, we are talking about both glaucoma and the disc suspects. And it was a comparison between artificial intelligence and the teleconsult doctors. The vision center doctors are teleconsult doctors who are the senior residents. Now they are second year, at the end of second year or third year, or sometimes even the fellows who have just joined with us do the teleconsultation. So what we saw was, this is just to compare between the AI and the VC or the teleconsult doctors, the sensitivity was 73% and the specificity was as good as 98%. And you can see the positive predictive value and the negative predictive value. But the point what we noted was, in the vision center doctors, there were more of disc suspects than glaucoma. So then we got a subset of patients who were referred and who came to the base hospital. The patients are still coming, but we were able to analyze some 70 patients referred to base hospital from vision center. Now, and then we compared between AI and the teleconsult doctors with, after all the investigations like HFA, OCT, the expert doctor diagnosis. Now we saw the correlation between these two. And if you see, like between the AI and the expert doctor diagnosis, it had a very good sensitivity and specificity, more than 90%. But if you see between the VC doctor or the teleconsult doctor and the expert doctor diagnosis, you can see the specificity is slightly low. That means they were the healthy patients were not detected properly. They're saying a lot of people as disc suspects and referring them. So what we saw was, even if they are trained doctors, meaning they have their MS or whatever degree, but they are under training, like residents here, they tend to overdiagnose glaucoma, in myopes or asymmetry in cups or asymmetry in disc sizes. But the AI is able to exactly say, this cup is because of asymmetry in the disc. No, this cup is a physiological cup in a myopic patient. The rim is good, no other features. So somewhere it is kind of improving the training of the teleconsult doctors also. So when they see this, when they see the RNFL defect, when they see the map there with the heat map, with those things, they also learn, and we found that the AI diagnosis was pretty much more reliable than even the teleconsult ophthalmologists when compared to the expert doctor diagnosis. So when you talk about certain glaucoma, you can see the numbers there. The sensitivity was as good as 96.4% for the AI, and it was 53.5% for the teleconsult doctors. So somewhere there is a major role for this in the future, and with that small result, we are still working on this. We are working to present at WOC and then even publish it. We found that the AI detects certain glaucoma with a very high sensitivity than the teleconsult doctors, and reduces the number of over-referral, which is very important for us. When you say a disc suspect, a myopic disc and all that to the base hospital, you are unnecessarily wasting their resources, time, and your time and resources in the base hospital, which can be definitely improved by doing this. And AI can potentially be used as a clinical decision support tool to improve the diagnostic consistency of the VC doctors. They can also look into it and improve their knowledge also about disc and the changes around the disc. And the AI performance to detect the referral warranted glaucoma when challenged with the fundus images was very promising when compared against a specialist with a full examination. So this is the interim results which we just got, but we are still working on all the other 299 patients to come to the base hospital. But again, it's a challenge to get them to the base hospital. Many of the normals are not ready to travel, so we are still working on that. But the point is, AI at this point of time, when we see and compare with the expert doctors, it's really doing a very good job. And we did even a pre-pilot before that in the base hospital. We found almost the same results. So there seems to be a very promising future to also improve the screening when you use something like this. So if you have a trained technician doing an imaging in a community, and then the software says refer versus no refer, it would be more than enough, because you have a reasonably good sensitivity and specificity. I think again, with this, I take this opportunity to thank Madam for conducting this course, and if you have any questions related to this, we'll be happy to take. Thank you.
He's very good with fundus pictures. He takes excellent pictures, and that's it.
The camera which Madam was showing you, called the iLike, is basically a refurbished plastic. It's made of a refurbished plastic, and Samsung phones. It's a company in Korea who makes that, and they are trying to partner with a lot of people in India to make the screening better. They have AI algorithms also, which Madam was showing you, to detect diabetic retinopathy and glaucoma and other changes. It's kind of very less expensive, but a very good tool.
It's trash to treasure, but it's more difficult than Remedio. Remedio is so much easier. Remedio boy does a wonderful job that he goes to outreach. These cameras we have given to vision centers. And those people, the yield, what you were saying is that we haven't compiled really as yet because it's new and the lots of images were not gradable to start with. The image quality has now improved, and the detection has increased. People who are good, significant amount of DR and glaucoma is being referred to hospital now.
Any questions?
The project is trash to treasure because they're using everything recycled. Even the phones which have been given away by people, exchange programs, and those are the kind of phones. I think no questions. I think then we are done, right?
Yes, madam.
Pawan, anything from your side? Nikhil, Mona, anything you guys want to add that you were not able to say then because of the paucity of time? So now we have another 10 minutes. My message is loud and clear that whatever is possible, do. Nothing is, if we keep on waiting till that everything is available, the cows will come home. So therefore, even something like a torchlight, Smith's test, or the Van Herrick's, if slit lamp is there. Otherwise, Smith's test is good. Shear tonometer is also good as long as something is done. Direct ophthalmoscope is really not bad if they're only plain cataract cams. Only one or two people are going. Everybody doesn't really have resources. But as long as the mind wants to look at it, that's worth it. Ideal ways we have already talked about that this is the way we can do. And innovations would be probably the key finally in the end, because we will not have so many doctors. We will not have so many trained optometrists also, because another challenge we are not able to decipher or not. Optometrists now want to go their own kind of practices, so there are very few. Like Nikhil has those vision technicians with 1 year training, but anybody who has a government kind of a degree, diploma in hand is setting up practice. So, and there will be multiple other things with that. So we really have to think as to where we are going and what do we need to do.